Adipocytic tumors represent a group of soft tissue tumors with differentiation towards the adipose tissue. The most common benign adipocytic tumor, and also the most frequent soft tissue tumor of the adulthood generally, is the lipoma. The usual localization is superficial in the subcutis, predominantly in the head, neck, shoulders, and back region. It poses no risk of malignant transformation. Macroscopically, it takes form of well-circumscribed bulk, movable against the surrounding tissue, and yellow on the cut surface. Lipomas are usually painless, except for angiolipoma. The most common variant, so-called conventional lipoma, consists of fully differentiated univacular adipocytes, without any cytologic atypia. Conventional lipoma is often enveloped by a thin fibrous capsule. However, some less frequent variants may contain a mixture of other cell types. We should mention angiolipoma, which contains clusters of the capillaries. The vessels are situated predominantly on the periphery of the tumor. They are often thrombosed and the tumor may be painful. Myelolipoma contains, apart from the adipose tissue, myeloid hematopoietic cells. The vast majority of the cases are located in the adrenal gland. Here we can appreciate the residual zona glomerulosa of the adrenal cortex. Spindle cell lipoma is formed by adipose tissue and undifferentiated spindle cells. Presence of thick bundles of collagen is a characteristic feature. They are a helpful diagnostic clue for cases with low amount of the adipose tissue, since they may be confused with various fibroblastic or fibrohistiocytic tumors. Typical localization of the spindle cell lipoma is neck and upper back region. There are some topical variants of lipomas as well. Intramuscular lipoma is located deep in the skeletal muscles, usually in the extremities. Its margins are typically infiltrative. Dermal lipoma is located superficially in the dermis. Dermal lipoma is forming a polypoid pedunculated lesion. Another benign adipocytic tumor is hybridoma. The hybridoma is a tumor with differentiation towards the brown fat. It's usually situated in the interscapular region, shoulders or thigh, and affects the adults. The color of the tumor is brown and consists of the admixture of mature univacular adipocytes and brown fat cells with characteristic finely vacuoled or granular eosinophilic cytoplasm. Lipoblastoma is a benign adipocytic tumor of the pediatric age, usually affecting children before the age of 3 years, especially boys. The extremities are a typical localization. Microscopically, there is an admixture of mature and immature adipose tissue in variable proportion. The mature component is represented by fully differentiated adipocytes, the immature component by lipoblasts. They are smaller fatty cells with multiple vacuoles in the cytoplasm and centrally located nucleus. Malignant adipose tissue tumors are called liposarcomas. They are common sarcomas of the adult age, and in contrast to lipomas, they are deep-seated, usually in the retroperitoneum or in the deep compartments of the proximal parts of the extremities. They are often large, exceeding 10 centimeters, with infiltrative margins, coarsely lobulated and yellow or beige on the cut surface. Regressive changes as necrosis, hemorrhages, and pseudocysts are common. We can subclassify liposarcomas into 3 groups according to their morphology, genetic profile, and biological behavior. The first and the most common group are well-differentiated liposarcomas. They are low-grade sarcomas with good prognosis. The metastatic rate is low. They are more prone to local recurrence, especially in the retroperitoneal region where the radical resection may be challenging. The more superficially located tumors, especially in the extremities, recur rarely, and some authors therefore recommend using a term atypical lipomatous tumor. Microscopically, they consist of relatively well-differentiated adipocytes. However, in contrast to lipomas, some immaturity of the cells is apparent. The adipocytes show variation in size and mild cytological atypia. Admixed with these cells are variably prominent cellular fibrous septae. They contain hyperchromatic spindle cells. The lipoblasts are a common feature as well. They are no longer regarded as a diagnostic requirement for a liposarcoma, since they may be found in lipomas as well, and their number in liposarcomas varies. Sometimes there is a prominent inflammation or sclerosis, which may even obscure the adipocytic component. In the course of time, the well-differentiated liposarcoma may progress and de-differentiate to a high-grade sarcoma. Such tumor is called de-differentiated liposarcoma. The morphology of the high-grade component may be variable, but usually resembles an undifferentiated pleomorphic sarcoma with the presence of markedly atypical and bizarre mesenchymal cells. The de-differentiated component is more aggressive, grows faster, and may overgrow the previous low-grade tumor. In these circumstances, the recognition of the liposarcoma may be challenging, if not impossible. The both well-differentiated and undifferentiated liposarcomas harbor distinctive mutation of the MDM2 gene, which may be useful for distinguishing these two tumors from other types of liposarcomas, especially the pleomorphic one. The second group consists of myxoid liposarcomas. They are low-grade sarcomas affecting predominantly the extremities. Retroperitoneal localization is unusual. The gross appearance is gelatinous in a lot of cases. Microscopically, the tumor consists of small lipoblasts, often containing a single lipid vacuole only. Therefore, the tumor may resemble a signet ring carcinoma. However, the true signet ring cells contain mucin, not a fat, and their immunoprofile is different. Another characteristic feature of myxoid liposarcoma is loose myxoid stroma with numerous thin-walled capillaries, branching in the chicken wire pattern. Analogically to the well-differentiated liposarcomas, the myxoid liposarcoma also may progress to a high-grade sarcoma. In this case, the de-differentiated sarcoma is of a small blue round cell type. Therefore, we use the term round cell liposarcoma. The third group is represented by pleomorphic liposarcomas. They are high-grade sarcomas with poor prognosis, localized usually in the extremities. A microscopical appearance is in fact identical to the undifferentiated pleomorphic sarcoma, with the presence of markedly atypical and bizarre cells and numerous mitoses. Only the presence of residual fatty cells can distinguish these two entities.